So we'll start here with a brief reminder of the anatomy of the airway. So remember the mouth and nose, we also are also known as the oropharynx for the mouth or the nasopharynx for the nose. Those join into the pharynx. And then we have the epiglottis, which is that little flap that makes sure food goes down our esophagus and water goes down our esophagus and that air goes into our trachea. So basically it just keeps food and water from going into our trachea. If you've ever been strangled on water or something, your epiglottis was probably not cooperating with you. Up next, we have the larynx, and that's the area where we have the vocal cords and things like that in the middle of the throat, basically. And then we get into the windpipe, which is the trachea, and that's the main access to our lungs. The trachea branches off that separation or that branch there is called the carina. Some people call it the carina. That's where the trachea branches off. And then we have the bronchi. The bronchi are where the trachea start to branch off into smaller and smaller airways. If you think of like a tree branch branching off into smaller branches, that's exactly what we're talking about. And then those branches get even smaller, and the next level is called the bronchioles. And the bronchioles are the tiniest little tubes that go to the most important part of our lungs, which are the alveoli. Remember, alveoli are just little air bubbles, essentially, or little sacs where we breathe the air in. Ideally, that air we breathe in has a lot of oxygen in it. That oxygen leaves the alveoli and goes outside of the alveoli into our bloodstream through the capillaries. So the blood picks up oxygen, and simultaneously, that blood is dropping off carbon dioxide through those capillaries. And so that carbon dioxide then enters the alveoli, trading places with the oxygen. And then we exhale more carbon dioxide and less oxygen than what we inhaled. So that's kind of the airway anatomy there. Respiration versus ventilation. So remember, respiration is the gas exchange. So that's what I was just talking about that takes place in those alveoli. It is where the oxygen that we breathe in goes into our bloodstream, and the carbon dioxide in our bloodstream goes into our alveoli, and we exhale that carbon dioxide. Now, it's obviously not as simple as that. There are a lot of other molecules that make up the air that we breathe. But if we want to go the most important parts here for airway, we're breathing in more oxygen, we're breathing out or exhaling more carbon dioxide. That respiration just means the exchange of those two gases. We also have ventilation, and ventilation is the physical movement of air into and out of our body. So when we inhale and exhale, that is ventilation. We need both to survive and to stay alive. We need to be able to move that air into and out of our body, but also once that air gets to our alveoli, we need to be able to exchange that oxygen and carbon dioxide so that our body and all of our tissues can get the oxygen that it needs, and also so that our body can rid itself of carbon dioxide and the other waste products that we're going to exhale out. So some common problems we can come up with respiration. So remember, we need both. We need respiration and ventilation. So if there's any problem with respiration or ventilation, that's going to result in difficulty breathing, not getting enough oxygen, things like that. So common problems with respiration could be environmental. Maybe there's carbon monoxide poisoning. You're breathing in something that you're not supposed to be breathing in, and you're getting that into your alveoli instead of the oxygen. Or perhaps the oxygen is getting to your alveoli, but then that oxygen can't get into your bloodstream. An example of that would be like pulmonary edema. Remember, pulmonary edema is where there's fluid buildup in the tissues of your lungs. So if you think about your alveoli, they're these little sacs. And surrounding those alveoli, we have tissues, our lung tissue. And if that tissue is full of fluid, that's pulmonary edema. Well, remember, the capillaries kind of lay on the surface of the alveoli, and that's where the oxygen is going to leave the alveoli and go out into the capillaries, into the bloodstream. And the carbon dioxide is going to leave the capillaries and come through those tissues into the alveoli. So if the tissue is full of fluid, that oxygen and carbon dioxide can't go straight from the alveoli to the blood. It has to pass through that fluid that's built up in the lungs. So that's going to cause a problem because there's not going to be enough oxygen loading on to those red blood cells in our bloodstream. And similarly, the blood is not going to be able to drop off that carbon dioxide that it's carrying. So that would cause a problem with respiration. We can still ventilate, we can still inhale and exhale just fine. It's just that the oxygen getting to those alveoli is having trouble getting further into that bloodstream because there's basically water in the way or fluid in the way. So if somebody's having a problem with respiration, all we can really do is give them a higher concentration of oxygen that they're breathing in. Maybe room air is not quite enough. So what we're going to do is basically dump more oxygen molecules into the air that they're breathing in hopes that maybe a few more molecules will be able to make their way through that fluid if it's pulmonary edema, or take the place of that carbon monoxide if they've had carbon monoxide poisoning. So that's what we do for somebody with a problem with respiration, is give them more oxygen. And we're going to talk about more ways to do that in a later presentation here. You can also have problems with ventilation. Now, there are many, many problems with ventilation. These are just a few examples that are probably the most common. So remember, ventilation is moving air into the body and out of the body. So one example would be if someone's choking. If their airway is occluded with food or some other object, they're not going to be able to move air into and out of their lungs because their trachea is occluded. Another example would be paralysis. If someone has a spinal injury, usually somewhere around cervical 5 or higher, the muscles that we use for breathing can be paralyzed. So they're not able to make their chest larger to pull air in and make their chest smaller to exhale out. If the diaphragm and all the the muscles between the ribs are all paralyzed, we're not going to be able to breathe. So that'd be another example of a reason who would not be able to ventilate. Another one could be fatigue, and this is a little bit vague here, I know, but if you think of someone who's been having difficulty breathing because of maybe pulmonary edema, like we talked about earlier, or basically anything that would be going on with the body causing difficulty breathing, you have to work harder to breathe, and we can only keep that up for so long. So eventually the person may become so fatigued that they can still move air in and out. There's nothing blocking the air or anything like that. But they're starting to wear down and they're using up their energy sources, and they can no longer breathe effectively. And so that would be another time they might not be able to ventilate. They're really just worn out. And we'll especially see this in children because they have to work harder to breathe. They're already breathing faster than adults at rest. And so with fatigue, that's going to come on much more quickly. And probably one of the most common problems with ventilation would be asthma or an allergic reaction. And I put these together because basically the same thing happens in the lungs for both an asthma attack and an allergic reaction. And that is that the bronchioles constrict. So remember that when we were talking about the different branches, we have the trachea that branches off into the bronchi and then the bronchioles. The bronchioles are those final little, really fine tubes that take the air into the alveoli. If someone's having an asthma attack or an allergic reaction, those bronchioles constrict, meaning they get smaller. So now you have basically a tube that's supposed to be letting air through it that's constricted down, and air cannot move through that tube any longer. That is what happens with an asthma attack or an allergic reaction. So the person's able to use their muscles for breathing, their trachea might be open, but when they try to breathe, those bronchioles are clamped off or constricted, and either no air or a very small amount of air is able to get into and out of the lungs. So that would be another common problem with ventilation. Okay, let's talk about the normal respiratory rate. So for an adult, a normal respiratory rate is between 12 and 20 breaths per minute, and this is at rest, somewhere between 12 and 20. A child, we're looking at 15 to 30 breaths per minute. That's obviously going to vary by age. Once they reach teenage years, we expect their respiratory rate to be the same as an adult. But when they're 2 years old, they're going to be more similar to an infant. For an infant, so up to 1 year old, we're looking at breaths of 25 to 50 per minute. And if we go all the way to neonate, like a newborn, it goes all the way up to 60 breaths per minute. So infants and children are going to be breathing much faster than adults at rest. And then, of course, when they're active, they'll also be breathing faster than an active adult. Now, normal oxygen saturation. Remember, we can use our pulse oximeter to measure a patient's oxygen saturation, or SpO2. The SpO2, the EMT textbook number they usually choose is that an oxygen saturation of 94% or higher is normal. If somebody's oxygen saturation drops below 94%, that's when we need to start considering possibly applying oxygen. Now, follow your local protocols on this. Here in Missoula, Montana, locally, our local agency, they go by 92% at this current time. So those could change, and they could vary from place to place. So follow your local protocols. But somewhere in that low to mid 90s range, we start to get concerned about oxygen saturation levels, and we start to think about applying oxygen. So follow your local protocols. Also keep in mind your pulse oximeter is not always accurate. The most common example of this would be that you'll see in the field is that somebody has cold fingers. If their hands are cold, a lot of times the pulse oximeter just won't read at all. It'll just say error, or it just won't read, like it's not on anybody's finger. Other things that can happen if someone has a carbon monoxide poisoning, basically the way the pulse oximeter works is it just uses a little laser to read the status of the red blood cells, to read, are these red blood cells loaded or not? And if those red blood cells are loaded, it says 100% or 99%. And the problem is that when someone has carbon monoxide poisoning, that carbon monoxide loads onto those red blood cells the same way that oxygen typically loads onto those red blood cells. So that pulse oximeter is going to come back and say, hey, 99% loaded, we're good. But in fact, those red blood cells are loaded with carbon monoxide instead of oxygen. So that person is not getting enough oxygen, even though their SpO2 might be looking really good. So always follow your basic training, that if somebody is having difficulty breathing, or if they're having any kind of symptoms of being hypoxic, in other words, low on oxygen, like we see discoloration of their lips or fingertips, usually they'll start to turn a little bit bluish first. That is a sign they're not getting enough oxygen, and you should give those people oxygen to help them breathe. So I think that's what we're going to talk about in the next presentation, is oxygen administration and the different options that we have for that. So I'll see you at the next presentation.